Yes, and in our first session today, we are going to be talking about caring for female carriers of Duchenne. So we're going to discuss not only the potential physical implications of carrying a mutated Duchenne gene, but also about managing those psychological effects involved with that diagnosis as well. And just as a, kind of a reminder, PPMD has been supporting a lot of work around carriers. We have a large natural history study that is ongoing at Nationwide Children's Hospital. We're going to be joined by some of the investigators from that study today. Pat Furlong is going to be leading our panel discussion this morning. And in that panel discussion, we're going to be joined by Dr. Stan Nelson from UCLA, who's going to discuss the genetics of carriers. And then we're going to be joined by a few providers from Nationwide Children's Hospital. So we have Dr. Ling, who's going to discuss the cardiac implications. We have Dr. Jamie Jackson, who's going to touch on the psychosocial considerations with carriers. And we will be joined by Dr. Kevin Flanigan as well on managing neuromuscular care. Dr. Ling and Dr. Jackson are both a part of that natural history study. As a reminder, when we get to the open Q&A, please feel free to submit your questions into the box below. And with that, we are going to start with Dr. Nelson from UCLA. So, Stan.
Thank you, Herc. Good to see you, Ryan. So I'm going to talk and set up how we'll discuss manifesting carriers or carrier issues and talk about the genetics and basis of how manifesting carriers occur biologically. Next slide. The DMD gene is located on the short arm of the X chromosome and was identified in 1986 by Lou Kunkel. And actually, X inactivation and chromosomal translocations were important for finding the exact location of where the DMD gene was years ago. And it is one of thousands of different rare Mendelian genetic diseases discovered so far. Next slide. Most of the mutations, are within a hotspot region in their deletions between exons 45 and 55, but deletions, point mutations, duplications occur throughout the gene. And that spectrum of most mutations are deletions, about 2/3, a second largest portion are duplications, followed by point mutations, either in splice sites or nonsense mutations or small frame-shifting indels occur throughout the gene, and that distribution is very similar everywhere in the world and everywhere that we look. Next slide. And that's true for carriers as well. I put this slide in just to remind us all that when we talk about deletions, even though two people, for instance, might have an exon 45 deletion, the exact boundaries of that exon 45 deletion can be quite variable, actually hundreds of thousands of base pairs different. And that's because exon 45 is tiny. It's about 200 base pairs long, but the intron, the open space before you get to exon 44 before, is over 200,000 bases big. So introns are huge, the exons are very small, and the breakpoints are almost always in these intron regions. And every family with an exon 45 deletion pretty much has a different deletion. We just didn't know the exact boundaries of it. So next slide. At the end of the day, what scientists learned decades ago was that the DMD gene is encoded over a 2 million base portion of the human genome on this short part of the X chromosome. And that sets up this issue of it being an X-linked recessive disease. It's encoded in 79 different exons, which has very important ramifications, as you've heard over the last several days in terms of exon skipping therapies. It encodes a protein called the dystrophin protein. And all of these things are actually quite relevant to what the causal effects are in carrier females. Next slide. The DMD gene is not expressed evenly everywhere. So the DMD gene is particularly highly expressed in nerve and in muscle, so in skeletal muscle and in heart. And these are sort of plots of looking at lots and lots of different humans, so that the gene itself is turned on fairly highly in skeletal muscle. And so much of the manifesting issues that will occur will, of course, be in skeletal muscle as well, or in heart muscle. Next slide. The reading frame of DMD decades ago was identified as being one of the most important features of knowing at a first approximation what the effect would be in a boy. That is, mutations that are out of frame, whether they're small or large, or cause a nonsense mutation, all lead to the same thing, which is pretty much no dystrophin made by every single nucleus of every single cell in that person's body. And it's particularly important in skeletal muscle. Boys who are born with a potentially larger deletion that's in frame, as long as it can make some dystrophin in every nucleus of skeletal muscle, will often have a disease that's called Becker muscular dystrophy. It can be quite a bit more mild, including people still ambulatory into for their entire lives. So quite a big difference between these two entities with clear mutations in them. Carrier status is a bit different. It's really that a portion of the nuclei in the muscle are turned off in a given person's muscle. Next slide. And that can account for an intermediate type of disease course or a manifestation of the disease phenotype. So we know for sure the amount of dystrophin in muscle is an important aspect of Duchenne, important aspect of Becker muscular dystrophy. And it's an important aspect of manifesting carriers as well, but just much less studied. So these are just different young men with almost no dystrophin, some revertant fibers here, small amount of dystrophin, but on every fiber, and then a much larger amount of dystrophin. And this person is the least affected of this set of three with Becker. Next slide. Skip this slide. Next slide. So this goes back to the point of DMD gene, because it's so large, because these introns are so large, every family has their own distinct DMD mutation. Almost all are new in a given family if we go back far enough. The mutation rate of the DMD gene is 1 in 10,000. This is about 10-fold higher than almost any other gene. There are some other large genes. So overall, about a third of the families have a de novo mutation in the child, and that's a germline mosaic mutation. And that's from a mutation that occurred in the mother's egg when she was in utero herself and her ovaries were developing. So it did not occur really during her post-birth life at all. So nothing that a mother did who was a carrier caused Duchenne in their child, but it occurred essentially before they were born. A third of the moms are discovered to be carriers, and they might have had a new mutation themselves and lived their entire lives without knowing. As Kevin will share, some of those folks, when you look back through the retrospective scope, you can then account for some mild phenotypes or severe phenotypes in some of the carrier females. And the last polling question is quite relevant to this in terms of how hard we or family or a woman looks back in her history. And there are stories of people being more severely affected young and then improving over time. And that's a story that we hear in clinic. Next slide. So DMD is an X-linked recessive disease. And this is how mostly we think about Duchenne. That is, a carrier mom is indicated in half purple, half orange. The orange is the reference allele, a normal DMD gene. The purple is a defective gene of any of the mutations that are discussed. So just consider it complete loss of function. Mom is half and is typically not affected. So this is what many of the pedigrees would look like. In this pedigree on the right, on the top, the mom to the far left with half of her circle shaded in is being indicated to be a carrier, but no comment about whether she is manifesting any symptoms or not. But for the most part, we consider in clinic many not to be having any issues. So you can have very large families, none of the females are affected, and males related through females are affected. And this is an X-linked recessive pattern that's been known for many decades in Duchenne. So typically, next slide, clinicians will discuss carrier females. and that's one normal X chromosome, one X chromosome with a DMD mutation. There's usually no or very mild muscle symptoms, and that's the typical. X inactivation should turn off in about a 50-50 ratio, the abnormal chromosome, and half the time the normal chromosome. Next slide. It's been recognized for my entire life that CK is actually a biochemical marker of the disease. And so this is a paper from 1962, gathering some papers from earlier, indicating that CK of carrier females, even though they're not manifesting issues, are often higher than typical. So this is kind of this middle group, and this is completely females without any mutations, either with or without exercise. So this has been known a long time that we can see a small increase in CK level, indicating some damage to muscles. So many females are actually manifesting carriers if we look hard enough at skeletal muscle. Next slide. These are a couple of biopsies of women who in their 40s are carriers with no symptoms, and dystrophin is expressed here at the edge, the brown stain here. And this is actually a very normal looking muscle biopsy with dystrophin on every cell. A woman with a carrier status as well, who is manifesting. She has a CK of around 2,000, has great difficulty getting up off the ground, walks with a substantial limp, and her thigh muscles are quite difficult for her, so she can't manage stairs in a normal way. At age 50, has some substantial changes. So she has some central nuclei, which is a sign that muscle fibers had to regenerate. Some of the muscle fibers are missing that brown stain without dystrophin. Others look pretty normal. So this is not a typical Duchenne biopsy, but it's within the range of a typical Becker muscular dystrophy biopsy, but because of a different mechanism. So some of the nuclei are missing it, and just enough of the nuclei are missing dystrophin expression that she's manifesting some symptoms during her life. Next slide. So of all females who are heterozygotes of a DMD mutation, one chromosome mutated, the other one not, so a carrier mom, about 70% will have at least a mildly elevated CK, and about 1 to 5% will have striking and clearly unusual manifestations of skeletal muscle weakness. And a smaller portion of those will manifest virtually complete Duchenne muscular dystrophy, and we've observed that along the way. A larger portion manifest important signs of cardiomyopathy, which will be discussed in more detail as the folks at Nationwide Children's learn more about what that state looks like. Next slide. So overall, when assessing potentially manifesting female carriers, CK is unquestionably useful. And I would typically do that on almost everybody who's a carrier for a couple of reasons. One is to know what it is. The other is occasionally young girls can have elevated liver enzymes. So knowing if somebody has a high CK means they're reasonably likely to have high liver enzymes. Knowing that that's due to being a carrier can avoid workups for liver malfunctions along the way. X inactivation studies are possible. You can look at skewing in the blood, but I'll show you a little bit of data indicating that this is pretty problematic study, in a few exceptions where it's, every cell has exit skewing of X inactivation, meaning that it's not random 50-50. Many, if manifesting signs, can be resolved by a muscle biopsy, and that's necessary in many instances with manifestations of skeletal muscle phenotype. It's also important to recognize that females can have a different muscular dystrophy, so getting to the end cause of it, that it really is manifesting carrier, is important. Next slide. So Kevin and I both overlap for some of these things, and we'll discuss it slightly different ways. So X inactivation is a complex topic. It's called lionization, or it's when women, girls' cells, actually before they're an embryo. So after fertilization and at a multi-day stage of pregnancy, when you're just a ball of cells, hundreds of cells, is when X inactivation occurs. And so that X inactivation is randomly turning off one chromosome or the other chromosome and then the cells are able to still move and still keep expanding. So then you get this random pattern of which X chromosome is turned off in every single tissue in our body. But there's some chance that the migration or the turning off could have been favoring one or the other, and then that leads to an uneven amount. And the way you can see this in real life is actually coat color in calico cats is because of X inactivation, as well as alleles for yellow and black coat fur. Next slide. So X inactivation leads to, it's a little bit of a fuzzy slide, but typical, the X inactivation is random in the blastocyst stage, and that leads to a developed female, where about 50% of every single tissue is the nuclei are turned off one or the other. In other instances, you could preferentially turn off the nucleus with a mutation, or you could preferentially turn off the nucleus without a mutation. So both are possible in this enterprise. It is a random. There are some instances where always the mutation will always be left on, and those are due to translocations. Next slide. This is a slide where I think this on the x-axis at the bottom are 0% to 100% inactivation of one allele in a buccal. So that's from your mouth epithelium. And on the left is epithelium, same kind of cell type, but in your bladder. So if you look at those two different cell types, here's a cell where about 95% of the inactivation is occurring in buccal epithelia, but it's about 50-50 in urinary epithelia from the same person, meaning that looking at X inactivation skewing in one tissue, blood, does not necessarily tell us what's going on in muscle. So these are data that we all recognize as a weakness of looking at blood X inactivation for inferring what's going on in muscle. Next slide. So the weakness tends to be quite patchy because of this randomness of the X inactivation, and the weakness may be treatable with steroids, and I think there's a strong recognition that this is likely reasonable to do. The effects in the heart are more common, and there are ways to treat that. Next slide. And that's the end of mine, so I'm going to boot it back to Eric and Ryan. Thank you.
Thank you, Dr. Nelson. That was a really clear explanation of what can be a fairly complex topic, so we really appreciate that. Next, we are going to hear about neuromuscular management, and that is going to be from Dr. Kevin Flanigan. So, Kevin, it's all yours.
Well, good morning, and thanks for the opportunity to take part in this year's conference online. It's really terrific. It's disappointing, of course, not to be able to see so many parents and colleagues and friends as we do each year, but I'm glad to hear that this is working quite successfully for everybody, and I hope that all the parents attending feel the same way. And thank you, Stan, for that introduction, a terrific introduction to the genetics. In fact, as you're saying, and I realize I'll skip kind of quickly over a couple of slides, just landing on one or two as we discuss X inactivation. I'm really predominantly going to speak about the neuromuscular features of this disease and present data from a study we published some years ago that gives some description of how this may manifest in women who carry mutations in the gene. If I could have the next slide, please. And that's just a disclosure slide that I'm on advisory boards for a few things. We'll go on, actually, skip the next one. Stan gave a great description about lionization, how there is in every cell in women, one of the two X chromosomes becomes inactivated. And if we'll move 2 slides ahead from this one, we'll say, you can go ahead and move 2 slides ahead, one more if we could. As a result, a way to think about this, just one more description of this, it's a random process in each cell, which one becomes inactivated. But it does mean that in tissues, there's variability of how this is expressed, the variability of inactivation, and therefore variability of mosaicism in an individual tissue in a woman, for example. Looking along the bottom line, it could be that if we think of the open cells and the filled cells as being sort of those that are affected or unaffected, we could see that it could range from predominantly unaffected cells to predominantly affected cells in a given tissue. Sort of visual representation of this X inactivation we've been talking about. If we could go to the next slide, please. So there's multiple mechanisms by which women can manifest with the disease. One is X inactivation, as we've been talking about it, this non-random X inactivation. Another route would be translocations, for example, translocations between an autosomal chromosome and the X chromosome. If that happens in a woman's cells, if they're it could be resulting in an inactivation of a locus, one of the two dystrophin loci on each chromosome. Therefore, a woman could manifest a mutation in the other X chromosome. And it is possible to carry two mutations, one on each chromosome, as I'll show you in a moment. A very, very rare situation. In fact, I'm aware of only one or two such cases that have been reported. And finally, we have to recognize that there are women who manifest with the disease in whom we don't come up with an explanation based on X chromosome inactivation, particularly when we measured in blood. Stan pointed out this difference between blood and other tissues in measuring it, but there are examples where we're not sure we ever find the cause, so it remains what we term idiopathic. If we could go to the next slide. I'm going to talk about data that we published some time ago, back in 2010, but really was out of a large database of patients. This is the paper, if people are interested in it, from neuromuscular disorders. And if you go on to the next slide, in this paper, it's worth thinking about how we define a manifesting carrier. And I'll say there's some discussion about this in the field, what we count as manifestations of the disease. Many people, as we just saw in the poll that was done, have muscle aches or myalgias, particularly with exertion, and the elevations in serum CK that Stan mentioned. We have a large project we've carried on for many years now called the United Dystrophinopathy Project. And in that database, we determined manifestation, classified women as manifesting carriers if they had any signs at all, including myalgias, muscle aches alone. But in our published study, and in some common parlance as well, we often use the definition of manifesting to mean women who've had either signs and symptoms of skeletal muscle weakness or the cardiomyopathy that can be a predominant feature for some people. And you'll hear more about cardiomyopathy in carriers in a moment. And there, I'll just add to say again, there's some discussion among the field, including advocacy groups, including among researchers, including among clinicians, about how we use this term manifesting. But I think there's a general agreement, certainly, that muscle aches and pains, and certainly weakness or cardiomyopathy fit that description. If we go to the next slide, I'll just note that when we did this description, I'm going to present data out of the cardiomyopathy, or out of our clinical manifesting set of patients, from what at the time was a large database of patients with about 1,200 patients enrolled. That's a more current measurement, about 1,200 patients enrolled in the United Dystrophinopathy Project. When we looked at the time, in our next slide, we actually presented that data among 860 subjects on our next slide. Waiting for that slide. So we actually only had 15 manifesting carriers among the total 860 subjects who had registered, who had manifestations as defined by weakness, in this case, weakness or cardiomyopathy. And the age and symptom onset in those women ranged from 2 to 47 years, with a median of about 8 years and a mean of 14.9 years. So the 7 of them had no family history whatsoever. 8 had affected family members. So 7 were the presenting complaint themselves. And muscle weakness was the presenting feature in 80% of them, and muscle aches and cramps were present in 60% of them. We broke up that characterization a little more carefully in more bins, let's say, with a group we called DMD-like. One of those 15 was described as having DMD-like, and 14 of them had more BMD-like symptoms that was ranging from severe to mild, or ones who were too young or we didn't have yet sufficient information. just to look at that a little more closely on the next slide, we use the term DMD-like if the progression really was indistinguishable from that of Duchenne dystrophy in males. And we called it severe if they began using a wheelchair before the age of 30, mild if they were walking after the age of 30. And if it was milder than DMD, but too young to be assigned to either mild or severe categories, we use that term BMD-like just in general. And then we sort of, independently of the clinical course, we sort of described at the last exam what that exam was and classified as mild or moderate or severe. And admittedly, these are rather qualitative descriptions for it. But if we go to the next slide, in that group, among women with skeletal weakness, 5 of them had dilated cardiomyopathy at the time of their exam. Now, this was echocardiography as performed in the decade leading up to the publication. You're going to hear later about cardiac MRI data from a range of carriers, so this is superseded in some ways, this data. But I'll note that there was, even those with the mild Becker muscular dystrophy type description, 3 of those had really quite significant cardiomyopathy. And one of them had a postpartum cardiomyopathy that improved with treatment. So it went from abnormal of 45% postpartum to 65% back well into the normal range. And the ones who had more severe disease, there's a small number, but both of them had cardiomyopathy, including one who had a really relatively rapid decline over 1 year at the age of 28 to 29, highlighting the need, even in this small group, for surveillance of women, cardiac surveillance of women who are carriers. And one woman had really cardiac dysrhythmia syndrome requiring a pacemaker implant later in life, even at a time when she didn't have ejection fraction abnormalities. If we could go to the next slide. We were a little limited in our study. We didn't have muscle biopsy in all patients. In fact, all 7 of the patients who were de novo, who had no family history, underwent muscle biopsy. And I only put this up there to show that the most common finding is this mosaic pattern. We can see here in the example, the DMD-like patient on the right in the control tissue in what's called the immunohistochemical stain. That brown stain represents dystrophin. And you can see that all fibers stain appropriately. And on the left, the DMD-like patient had very much what looks like a standard biopsy in boys. We see what we would call some revertant fibers. Here we photographed a cluster of those revertant fibers that do express it, but the vast majority of myofibers do not express dystrophin. We'll go to the next slide. This is a terrible slide. I realize reading it on your screen must be quite bad, but this is just describing some of those muscle biopsy features in the patients with the ages at the biopsy. And if you look at the far right, at descriptive terms of the histochemical staining, it ranges from scattered negative fibers or fibers with reduced staining in comparison to control into ones which had essentially no staining of control in that sample. And this is one of the challenges of the biopsy diagnosis. As Stan mentioned, there is variability in what muscles are weak in some carriers, and we can see patchiness or differential staining depending which muscle we sample. So in a woman who's symptomatic, who has any variability in dystrophin staining, we have to consider it. We'll go to the next slide. So in this group of patients in whom exon activation studies were performed, they were informative in 14 out of 15 patients. One of the patients had an uninformative result, which can happen with clinical exon activation testing. And one of those 14 patients, we had another explanation for her disease. She had, in fact, 2 mutations, one on each copy of the DMD gene causing her disease. Skewed exon activation as detected from blood was only found in 5 of the remaining 13. So in fact, it was detected in only about 40% of those patients. And 2 of the subjects who had normal exon activation, 2 of the patients who had 100% skewing of exon activation, we found no other evidence of rearrangement on the X locus to account for this skewed pattern of activation. So one more slide, and I'm showing on the next slide, again, very hard to read tables about this. I do apologize. I forget sometimes particularly when we do Zoom ones, if you're reading on a laptop, I apologize for this. But in bold, you can see some descriptions of the skewed activation and the type of mutations we found. So we found a whole range of this among patients. And I think because of the difficulty in reading this, we'll go to the next slide and follow up with slide, then 2 slides ahead to slide 18. So to summarize, and I think the important issue for manifesting carriers is this, that skewed exon activation is not detectable blood in our hands in the majority of manifesting carriers. We often see it and attribute it to that, but it's important to know that it doesn't reflect always what's going on. And we now have the easy availability of complete sequencing. So particularly in cases where girls with Duchenne or Becker-like symptoms exist and there is no family history of disease, it's obligatory to make sure that both chromosomes, both dystrophin genes are tested. In other words, if a girl without a family history has a deletion detected, we should still proceed to sequencing to determine whether or not there's a separate point mutation on the other gene, on the other dystrophin gene, on the other chromosome, the other allele. And I'll just give the demonstration of that. If we go to the next slide, this is an example of such subject. A patient who had random X chromosome inactivation, non-skewing, had an out-of-frame deletion of exons 8 through 13 that had been previously reported as associated with a Becker or Duchenne muscular dystrophy, but then had a second splice site mutation with an intron 69 just adjacent, in fact, to the exon, and it was previously reported as Duchenne muscular dystrophy. And in fact, there was no maternal DNA revealed, no maternal DNA, no mutations in the maternal DNA. And unfortunately, there was no sample available for analysis from her father. So this can exist. So if we go to the next slide, I'll sort of return to this sort of one of the major things. I think one of the questions that comes up all the time for us is, should women who are affected be treated with steroids, and how do we decide about that steroid use? We're limited here, we're going to talk by analogy to Duchenne muscular dystrophy and Becker muscular dystrophy. We just don't have huge numbers of patients or randomized studies in women. So we have to make some decisions for treating girls and women who manifest with this based on what we know from male patients. And of course, we know that prednisone and deflazacort both delay the loss of ambulation. This audience knows very well that this probably acts through multiple mechanisms, primarily or particularly through decreased inflammation and fibrosis within muscle that's being damaged by mechanical stress. Probably some stabilization of the sarcolemmal membrane, the myofibril membrane itself. And these are mechanisms that are active whenever there's insufficient dystrophin, whether it's boys with Duchenne dystrophy or in female DMD manifesting carriers. So we make treatment decisions really based on analogy to male patients. So just as we don't treat mild or moderate Becker muscular dystrophy patients with steroids, we don't do that in the case of Becker muscular dystrophy because the risk-benefit ratio of long-term steroid use probably is certainly the risk factor goes up with years or decades of use of it. So we have to make the same decisions in women by weighing these risk-benefit ratios in the same way. So in our clinic, girls who are manifesting DMD carriers look as typical DMD or close to typical DMD, or they will be treated by the same regimen that we offer for males, either daily prednisone, weekend prednisone, or daily deflazacort, one of the acceptable approaches to that. Of course, we in those same patients, we pursue the same kinds of care that we do for boys with Duchenne, offering the same sort of nighttime splinting as a key role early on with this to try to maximize ambulation, and pursue a very aggressive course of monitoring for cardiac and pulmonary manifestations or complications of disease, just as we do with boys with Duchenne. And we'll hear more about that, about the our sort of monitoring of cardiac data in my colleagues' talks in just a couple of minutes. So with that, I'll close, but I just want to acknowledge I presented some data on relatively old data, but I think that still holds up very well. My colleague Bob Weiss and Payam Sultanzadeh now at UC Irvine, who helped to do this, and Michael Fries from Greenwood Laboratories, who really did all the X inactivation studies for us. Thanks very much, and I'll turn you back over to the studio now.
Thank you, Dr. Flanigan. I think that really highlighted just how variable the presentation can be in carriers. And of course, that variation can extend to how the heart is impacted. And so to discuss those cardiac implications, we are going to be joined by Dr. Ling Ma. So Dr. Ma, if you are ready.
Thanks, Eric. So I will echo Kevin's sentiment that I wish we were all in person. I do appreciate the opportunity to put on lipstick, I think, for the first time in about 4 months. We've all been wearing masks, and I think 5 days out of the week, I'm wearing a goggle, a gown, and a mask. So this is a unique opportunity. I forgot to put in a disclosure slide. My only real disclosure is that there's, I guess, an off-label use of Frozen 2 to keep my children quiet for the moment. It doesn't work for my dogs, and so I'll apologize for any ambient noise we have during this talk. So this is a culmination of a large project done at Nationwide Children's that Eric had alluded to. We studied both Becker and Duchenne muscular dystrophy carriers with the generous funding from PPMD, and it is a longitudinal ongoing study. We have analyzed our year 1 data, and that's mostly what I'll be presenting to you today. The questions that we really sought to answer, it truly is a natural history study, and in large part, I think all of us wanted to jump to a treatment trial, but the reality of it was there were probably more questions than there were answers when we started out on this journey. So we really wanted to know, does carrier cardiomyopathy really exist? I think we're all in this group anyway, believers that it does. There were real variances in terms of description of prevalence of manifestations in carriers, and so we really wanted to kind of hone down on how often are we seeing it and what are we seeing. We also wanted to discuss how we look for cardiomyopathy. Many of the historic studies rely very heavily on echo, and we just really didn't want to rely on that. Oh, I'm sorry, you can go to the next slide. So we went through kind of the process in terms of how do we put together a study that would help us establish guidelines, both from a genetic, a cardiac, a neuromuscular, and a treatment standpoint. Obviously, the treatment standpoint is much later. So we really put together this longitudinal study without an intervention. We included cardiologists, neuromuscular specialists, psychologists, and Dr. Jackson will talk to you about her portion of the study next. But we really wanted to look at it from a multimodality, whole person view. We wanted to look at not only what it looked like, but also how it behaved, because we felt that that was really vitally missing from a lot of the studies that are before. We know that you are not just your echo. And so because of that, we wanted to be all inclusive in terms of how we really looked at this. Next slide. This culminated in the publication of this paper fairly recently, within the past month, in the International Journal of Cardiology. It basically goes through in pretty significant detail all of the findings we found from a cardiovascular standpoint. So much all of this data is present in that journal article, and so this will be a quick review of what we found. Next slide. So what makes a mom a carrier versus a non-carrier? And so obviously, as Kevin and Stan have done very elegantly, it's defined genetically. So some moms are genetically proven carriers, and for the purposes of our study, we refer to it as a carrier mom, or an MDC, or muscular dystrophy carrier. Some moms don't carry a gene that's known to be causative of DMD and BMD, and we refer to those as non-carrier moms. So some of the women who entered our study did not know their genetic status in advance, and so all of the women, when there wasn't genetics available, either were retested, and if there were questions about the initial testing, they were retested. And so we felt very comfortable that we had a clear population of women who have known causative genetic mutations and women who did not, but had sons with DMD and BMD. We discovered that not all carrier moms are equal, and I think that both Stan and Kevin have described that in much greater detail than I could ever offer you, but that also appeared to be the case clinically. Next slide. Our participants were moms with DMD and BMD affected sons. They were all genetically tested. We ended up with 77 muscular dystrophy carrier moms, 22 non-carrier moms, and then we also enlisted 25 healthy controls out of a population of women that were employees at Nationwide Children's. We age matched them, and they went through the same battery of tests as our other 99 women. The age ranges were not different in our three groups. Their ages ranged from 28 to 63, and the average age was in the early 40s. For the split, we were actually pretty happy to see our split being 77 and 22. As Stan discussed, there is a 1/3 of women don't have genetic mutations, so we felt like we had gotten a nice sample of women that were reflective of really the population that we were talking about. Next slide. So to answer the question, does carrier cardiomyopathy exist? What we thought we knew was all based on these echo studies. And it was often felt that cardiac disease was the only manifestation with milder disease, or what Kevin alluded to as BMD-like disease in most of women. The carrier cardiomyopathy risk was really variable, though. And when you look at different studies kind of over a decade, when you looked at women based on their ages, very few of them actually ended up being diagnosed as having cardiac disease. And so, in the third through fifth decades, it was reported to be about 9%, and greater than 50, about 15%. And so in some ways, I felt like this was a real disservice, because when you're reporting prevalence rates that low, it was felt to not really be that substantial of a problem. And because of that, the cardiac disease definition never really got fully vetted. And I think that echo is just limited that way. And unfortunately, that's what we had. And that was the diagnostic tool of choice. And so that's what we used. Next slide. So we decided to go after two different routes, and really both looking at function and what your images look like. And the images by cardiac MRI and the function by treadmill. And the answer was yes, there is a carrier cardiomyopathy. And what would it look like? I feel like we have a better grasp on after having done the study. So there were treadmill differences. A treadmill test is what it sounds like. We put you on a treadmill. We try to get you to run on that, or walk to run on that treadmill for about a 9 to 10 minute period of time. I'll show you a picture of what that looks like. But there's a full face mask, and we measure ventilation, carbon dioxide. We measure all of these things that can help us get a sense of the energy expenditure and the energy in which the aggregate of your heart and your lungs and your muscles are giving you. So on these treadmills, we saw that there was a higher risk of arrhythmias in the carrier moms. Now, these arrhythmias on the whole are benign. If we were to see you in clinic and do a Holter on you and see anything less than 4,000 of these in a 24-hour period, we would consider that normal. And so they were certainly not what we would refer to irritable heart muscle. And we saw it in about 25% of carrier moms, mostly in the early recovery stage of exercise. That can happen in other disease processes as well. When you stop exercising, there's a very kind of complex physiologic response that happens. It's why people often pass out after exercise or throw up at the end of exercise. And that process of recovery looks really different in carrier moms in comparison to non-carriers and in our controls. So while 25% of women showed us this arrhythmia in early recovery, only one non-carrier mom and none of the controls demonstrated this finding. This finding also then correlated with a fibrosis pattern on MRI. So obviously all of these women went through treadmills, followed by MRI, and it really did correlate. And so this pattern of irritability has been shown in other cardiomyopathy diseases, clearly not muscular dystrophy myopathy, but other myopathy processes. In year one, we didn't have anyone string these together. In other words, having 3 of these PVCs in rapid succession. We did have one patient in year 2 demonstrate that, and we felt the need to treat that because that would be a more substantial finding. Next slide. So the MRI data was also fairly remarkable. So fibrosis was seen in 49% of the carrier moms, only in one non-carrier mom, and in none of the controls. The location and the pattern of the fibrosis has been reported before, and that also mirrored that of the boys. It's the subepicardial pattern in a very predictable location when it starts, and then it seems to expand kind of in that subepicardial plane all the way around the left ventricle. That exact same pattern that we see in boys, we saw in moms. Next slide. So we really feel strongly that cardiac MRI improves our disease detection. So as I had said previously, usual reports of dilated cardiomyopathy or abnormality by echo, those were about 9 to 15%, depending on the study you looked at. And we really found that almost half of women have abnormalities by MRI. The MRI technique we used was gadolinium contrast, and that's the same thing that we do in the boys. We additionally did some T1 mapping. T1 mapping, just to explain it, is a timed response to a change in MRI environment. Dr. Con Hoare is the one who did all of our MRIs. He's an expert in cardiac MRI and muscular dystrophy. And what you do is you exert the magnet to a change, and then the correction times are measured, and those correction times have been shown to be slower in people with diffuse fibrosis processes in their hearts. And so you don't have to have frank scar tissue like we see, and we did see in about half of women, but you can also demonstrate kind of findings that are more subtle in terms of just having a diffuse process of fibrosis that would slow your T1 times that are also suggestive of fibrosis. And we also did this. Next slide. So this slide isn't showing exactly as I had intended, but what you can see in the grayscale pictures are red arrows that indicate the LG fibrosis. And so if you'll know, going across on the picture on the right of the screen, it's a blown up picture to expand, but the control is the top 3 frames. The non-carrier mom is that second row across, and then in the third row was an affected muscular dystrophy carrier. The grayscale pictures are what we see in terms of LGE, so the gadolinium abnormality and fibrosis. And it's very hard to tell in the picture. I tried to give red arrows to help with that, but there's this thin crest of white kind of in what we call the subepicardial layer. That's the layer right underneath the outside portion of the heart muscle. And that thin crescent of white is abnormal and is considered fibrosis. T1 mapping is shown in that last column for each of the patients. And green is faster than blue. And so when you look at it, it gives you a real kind of visual picture of slowed times throughout the myocardium that is abnormal. And so we felt that this was very helpful prior to showing frank fibrosis, which we think is, while MRI is more elegant than echo, it is a much blunter instrument than looking at T1 mapping. And so when we looked at T1 mapping times, it was also fairly remarkable how different the pictures looked. And I think for the purposes of this presentation, it really gives you a visual as to kind of what is different in terms of the heart muscle. And we felt that this finding was unique and fairly remarkable. And we spend a good amount of time discussing it in terms of the paper. Next slide. So what do the T1 maps tell us? And so when you look at the actual times, I'm giving them to you in milliseconds because it's quite fast. The carriers had T1 times that were slower than the non-carriers and the controls, and obviously in milliseconds, it was statistically significant. And in the context of T1 maps, it was a substantial difference. The nice thing about using T1 maps is we can assay for diffuse fibrosis, but we can also do it without the use of contrast agents. And so there were at least 2 women who either we couldn't get an IV in or they didn't tolerate the contrast, that we couldn't use contrast. And so in the absence of an ability to use contrast, this is a really beautiful way of being able to say, I think you may have some fibrosis. We also looked at it because then the question was asked to us on the review of our paper, can you use this to screen for who is and who is not a genetic carrier? And the answer is absolutely not. And so the next slide, so while we like it, if you could advance to the next slide, while we like it in terms of use of fibrosis, we did not feel it was robust enough to say you are or are not a genetic carrier purely based on the MRI. I put this slide up as evidence that we really, really, really need to have your genetics. For those of you who hated statistics in school, this is an ROC curve, and it basically studies kind of how well did the test behave in terms of predicting who is and isn't a carrier. And on the curve on your right, the better curves head up to your left upper hand corner, and you can tell it while it's predictive, it's not just a random, which is the red line. It does start to go up. It is absolutely not robust in terms of saying who isn't a carrier. We really feel strongly after this study that genetic testing is really key. Next slide. So then we looked into how we can predict which carriers are at risk for fibrosis. So age certainly is a risk factor. So carriers who had fibrosis were older. They were 44 years of age on average in comparison to 39. The youngest carrier manifesting LG positivity was 31. There was an odds ratio of 10 per decade for having fibrosis, which is to say that a 45-year-old would have a 1 in 2 odds of having fibrosis. If we saw any PVCs in recovery of exercise, that was also highly suggestive that you were going to have fibrosis on your MRI. And a full 40%, almost 40% of those who demonstrated a PVC in recovery did actually go on to have LGE positivity in terms of the MRI. Next slide. So the next question is more important, and what does carrier cardiomyopathy really look like? And so this is actually one of our old research coordinators, and Michelle Slawinski, who is the exercise physiologist who performed the vast majority of all of these tests in our treadmill suite, doing a test. And I think that this is important to know because this is not an easy test. Next slide. When these women if you could move to the next slide, thank you. When these women got on the treadmill, I have to say it didn't look so bad. And so I almost feel that this is more important than some of the MRI findings we found. What we really looked at is your functional capacity. How much energy did your body give you to do it? And it was not different between carrier moms and non-carrier moms, and only very slightly lower than the control. And so while we see the fibrosis, you guys are able to do pretty well. And the treadmill test is not for slouches. It really will pull it out. We get you to maximal testing. And there were no cardiac specific measures of limitation, and no participants stopped due to muscle limitation. And so we were really impressed by that and quite surprised. But this is a real positive out of the study. Next slide. For the MRI findings, while we did see that the fibrosis was more common, the average left ventricular ejection fraction was normal. So carrier moms versus others, it was 58% versus 60%. That is within a range of error. I did not think that was a specific difference. It was not a clinically important finding. 5 carriers had abnormal LVEFs, and all of those women had fibrosis. We described abnormal LVEF as less than 52. We did not have any women with LVEFs of less than 40, and all of the women that were less than 52% had fibrosis. So like the boys, fibrosis is the leading find prior to a drop in function. Next slide. In my final thoughts, I really think genetic testing is key. Cardiac disease and muscular dystrophy carriers is both real and prevalent, and more prevalent than I think it has been felt to be historically. Importantly, though, and I think this is a big message, is that the third of you that are non-carriers that do not have the genetic mutation do not need to see a cardiologist. I suspect you're pretty plush on doctors in terms of your family, and so kind of taking that stress off and saying one less person is not a bad thing. So for me, I think that you don't need the cardiac MRI, you don't need treadmills, all of that is off the table for you. And I think that that's hugely relieving, and I think a big reason to get genetic testing. There is no clear connection between the boys' cardiomyopathy severity and onset or the specific gene mutations. And the functional status of a relatively young cohort, 30s to 60s, is still quite good. The LVEF decline trails fibrosis. Oh, sorry, next slide. So LVEF declines trail fibrosis. Age matters. I recommend an MRI in the third decade of life, ideally with gadolinium, but if you can't, then I'd ask for T1 mapping. We can possibly make an earlier diagnosis, and it becomes increasingly important as we talk about treatments to have lead time in terms of treatment and prevention strategies. Next slide. So this is cautious optimism. I will share with you one patient that I have seen recently because it's an instructive or an illustrative and hopeful story. And I share this with her permission. She's a 47-year-old woman who is a DMD carrier. She is functionally asymptomatic. She had an MRI in 2001 at the age of 29. She actually doesn't know why she got that MRI, and I got the report for it. They reported an LVEF of 30 to 35%. So she would have been younger than our youngest manifesting carrier in our study. No cardiac therapies were initiated at the age of 29. I think it was a head scratcher, and then she was just lost from care. In March of 2019, and so not long ago, she was 47. She was admitted for heart failure. She had shortness of breath, and an MRI was repeated, and her LVEF was 28%. So not substantially different than the one she had had over a decade, almost 2 decades before. I saw her in April, and we started heart failure therapies with a pretty aggressive up titration over 6 months, and she did great with it, but we really pushed her. And in follow-up, really 2 weeks ago, when I saw her, her LVEF improved to 40 to 45% by echo. We'll substantiate it by MRI soon, but I opened the study when I went to read it, and I almost thought it was on the wrong patient. It really had changed. Some dystrophin means you respond to therapies, and I think that this is an antidote. And I think that, to me, it really whets the palate for kind of the next steps. And I think that we can all have hope that identification is step one, but definitely don't lose heart, because I really think that there's something to be done and can be done. Next step. Next slide. So in conclusion, I'd like to thank all of the families that participated. And I know that it wasn't just the moms who suffered through treadmills with us. It was also the families, and what they contributed was really, really tremendous. And I remind everybody that not only was it 99 families, it was times 3 years, times 3 IVs, sometimes more, depending on how hard of a stick you are, times 3 MRIs, times 3 treadmills, and times 2 days of testing. So it was really a gargantuan ask, and the community certainly came through. I would be remiss not to acknowledge PPMD, as well as the Heart Center Research Program and Nationwide Children's, for funding the project. And then to show, next slide, the slide of our whole team, and it leaves out many people, but could not have done it without the entire team. With that, I'll send it back to Eric and Ryan.
Thank you, Dr. Ma. We really appreciate you sharing those excellent insights from that first year of the natural history study. Our next speaker is Dr. Jamie Jackson, and she is going to touch on the psychosocial considerations for carriers. So, Dr. Jackson, if you're ready.
Thanks, Eric and Ryan. I appreciate it. And a big thank you to PPMD for the opportunity to be here with you all today. And a big thanks also to Dr. Ma for a great introduction to the carrier trial. I'm going to kind of dub this the psychosocial arm of the carrier trial that I'm going to be discussing with you today. And I'm going to use that as a way to guide my discussion about psychosocial well-being, both what we've learned from the carrier trial as well as where we need to go next. So really quickly, I wanted to orient everybody to some components that we included as part of the psychosocial arm of the carrier trial. First and foremost, one of the things that we wanted to examine was caregiver stress among the moms who were involved in the study. What we know from research is that caregiver stress takes a tremendous toll physically and emotionally on caregivers. And in fact, it's one of the most stressful things a person can experience in their lifetime. For our study, a majority of the women who are involved were currently caregiving for a son who either had Becker or Duchenne. And this undoubtedly was going to play a role, we believed, in not only the psychosocial well-being, but potentially could also have an impact when combined with an individual's genetic status. And I'll get in a little bit more to the genetics a little bit later. When I talk about psychosocial well-being as one of the components, this is really how I'm conceptualizing the outcomes of the trial. And it's a really general term, and I'm using that term generally on purpose. We really included quite an array of outcome measures to measure this concept of psychosocial well-being. This included self-report of emotional functioning, health-related quality of life, and even somebody's self-report of their physical functioning, according to how they perceive themselves to be doing physically. And then lastly, as I'd already alluded to, genetic status was another factor that we were interested in particularly the interplay between these factors, as I've kind of denoted by that little yellow star in the middle. And really, these things do not exist in isolation. And in fact, it's the combination of these things that really is of true interest to us as part of the psychosocial aspects of the carrier trial. Next slide, please. So the first part that I would like to talk a little bit more about is the relationship between caregiver stress and well-being among the moms in the trial. And the data that I'm going to present here today are data that are currently under review at a scientific journal. Just to kind of start us off in thinking about this relationship, there has been research done on the caregiver stress for those who are caregiving for a son with Duchenne or Becker. Those studies have largely been qualitative, though there have been quantitative studies as well. One of the things I think that's lacking in the research up to this point is the use of an appropriate comparison group in which to compare those individuals to. And, in our current study, we intentionally had recruited controls to be part of the study, as Dr. Ma had already discussed. And as part of the controls that were involved in the study, a majority of those controls were nursing staff at our hospital at Nationwide Children's. And somebody may ask, well, are nursing staff really a good representation of women out in the general public to compare our women who were involved in the study? And you might think not, because obviously nursing staff are incredible individuals, and they might not exactly represent everybody out in the general population. However, in comparison to our mothers, they actually were quite a good comparator, and for several reasons. One, obviously, we age matched these women, and that's important because we know that psychosocial outcomes can vary over time as individuals age, so that was important. But they also matched quite well sociodemographically. So as far as level of education, annual income, other factors that are also important to consider when we're measuring psychosocial outcomes. And in addition to that, nurses have an incredibly stressful job. And there is a high degree of burnout among nursing staff. And so we also thought it would be of great interest to compare some individuals who already have higher levels of perceived stress as part of their job to our mothers who are caregiving. And so again, ultimately, the question we wanted to ask is, do these women in fact differ when compared to one another on our psychosocial outcomes? Next slide, please. So this first slide is showing differences between mothers and controls on health-related quality of life. And the particular measure we used is something called the RAM36, which has 8 primary subscales that range between self-report of how one's health is impacting their physical well-being, their emotional well-being, their social well-being, so on and so forth. And what I want to highlight is the little red asterisk that you see above the mothers indicates that statistically, mothers are reporting poor quality of life across the board. Next slide, please. And then this is a slide representing some emotional distress data. So on the left-hand side, we have reported symptoms of anxiety and depression using the Hospital Anxiety and Depression Scale, also known as the HADS. And once again, a similar pattern emerges where mothers are reporting higher levels of anxiety and depression. You can also note on the left-hand side, I have a little red line, if you can read it, that says clinical on top of it. And this is to actually denote where the clinical cutoff is on this particular measure. So if you score at like a 10.5 and above, it's considered clinically elevated symptoms. And you can see that our moms are kind of nearing that clinical cutoff, but as a group, they don't quite supersede that cutoff. However, I think it's important to note 39% of the mothers that have participated in our study reported clinically elevated symptoms of anxiety. And this is in comparison to only 19% of our controls. And that's pretty striking. On the right-hand side, this is self-reported perceived stress. And once again, as denoted by the red asterisk, mothers are reporting significantly elevated levels of perceived stress as well. Next slide, please. So what do we still need to know, though? Dr. Ma had mentioned that this is, in fact, a longitudinal study. And so one area of interest of ours is also to track the psychosocial well-being of our mothers over time and how that psychosocial well-being changes. We're also documenting mothers, their perceptions of how their sons are doing. And it will be important for us to examine whether if there are changes in how mothers perceive their sons to be doing, does that actually drive, in fact, how mothers perceive themselves to be doing as well? While this is a relatively still brief snapshot, because, we're really only following women ultimately over a 3-year time period, I think in thinking about future research endeavors, we really do want to think about the long term of both from the point of diagnosis and following those women on to see how, again, caregiver stress may impact their psychosocial well-being over that time period. Another thing for us to consider, and I know that we're focused on carriers today, but I would be remiss not to mention also the psychosocial experience of fathers. As families know, if one individual is impacted by something, for example, like caregiving stress within a unit, this also has an effect on the other individuals within that family. And so even when we're still backing up to consider, the well-being of our carriers and our mothers, how fathers are doing undoubtedly will also have an impact on our mothers as well. And we do know less about this experience among fathers. And I think lastly, and also very importantly, we really do need to take a look at this data in consideration of how to best provide psychosocial support for these mothers. If we have almost 40% of our sample reporting clinically elevated levels of anxiety, this needs to be addressed. And unfortunately, the way that the treatment system is kind of set up where, a lot of boys will be receiving psychosocial care within the context of a children's hospital, for example, possibly where they're receiving treatment, there are not opportunities for care for that mom necessarily at that institution. And instead, moms are going to have to go outside of the institution, find yet another provider, another doctor to fit into an already burdensome schedule. And I think this really is a true barrier for women in receiving care and is something for us to consider moving forward. Next slide, please. So let's now talk a little bit about that relationship between genetic status or carrier status and psychosocial well-being. This is an area that has much less attention in the kind of psychological literature overall. And so we are going to be one of the first studies to really compare the differences between individuals who are muscular dystrophy carriers to those who are non-carriers across multiple domains of psychosocial well-being, including cognitive functioning as well as emotional health. And so that was one thing that we also wanted to set out to do, was see whether or not there might be a difference in these women, in part because a lack of dystrophin is hypothesized to be a potential driver for cognitive deficits or other symptoms of anxiety, elevated levels of anxiety amongst the boys. And so we wanted to see whether or not a similar pattern would exist among muscular dystrophy carriers as well. Next slide, please. So in this context, when we're defining psychosocial well-being for this particular set of analyses, there were 3 things that we had included in this. First, we included a cognitive screener, the WASI-2, which, again, as a screener, is just a very broad tool to see whether or not there is a presence of cognitive deficits. We also asked women to report on their emotional health, and we've already seen a few of those measures already, and I'll talk a little bit more about one in particular. in just a moment, as well as self-report of physical functioning. Next, please. So in addition to anxiety and depression, which I've already shown you some of that data when we were looking at mothers more broadly or caregivers more broadly, in addition for these particular analyses looking at genetic status, we were also interested in self-report of obsessive compulsive symptoms, which you can see on the far right-hand side. That's in addition to just general anxiety symptoms. And then for self-report of physical functioning or well-being, we included a measure of fatigue. As we've already talked about, that there has been a lot of discussion about particularly muscle fatigue in women. So we wanted to see whether or not that extrapolated to just kind of general fatigue, as well as other general somatic complaints. Next, please. So for our particular analyses, when we looked at just muscular dystrophy carriers to those who are non-carriers, and again, all of these women have confirmed genetic testing, we actually do not see any differences identified. Next, please. So does that really answer the question? No, not yet. While I think this is a starting place for us, and this gives us some indications, I still think there are a lot of other things that we need to consider in moving forward with trying to best answer this question. First of all, does the location of the mutation matter amongst muscular dystrophy carriers? We had, too few women ultimately in order to be able to look at location of the mutation, and this is certainly something with a larger sample size, with more women that represent more locations, that we could certainly do moving forward. Also, we used a cognitive screener in part just because of, as Dr. Ma, I think eloquently put, these women had really been put through the ringer. A true neuropsychological battery can take hours to conduct. It's very time intensive. The benefit of it, though, is it's kind of like using a scalpel in the sense that it really can get into the fine detail of whether or not there are deficits. A cognitive screener like we used is kind of more like taking a hammer to it. It's not the most eloquent way, and it will really only identify large deficits rather than more fine-tuned or harder to detect deficits, unlike what a comprehensive neuropsychological battery would do. So moving forward, this is another consideration for research. And lastly, what role does the caregiving stress that moms endure, how does that play a role with genetic status on psychosocial well-being? Next, please. And that really is the interplay that we're very interested in answering as part of this study. We haven't quite gotten to the point where we have, analyzed this data, but this is next on the long laundry list of things that we want to look at in this study. And I think this is a very important question that we want to try to, if not answer, at least see whether or not we're starting to pick up a signal as to whether there is an interplay that exists. And, so just kind of backing up for a minute, we know that chronic stress and caregiver stress is included in this. It increases cardiovascular vulnerability among healthy people out in the general population. And as Dr. Ma had talked about, now we have evidence to suggest that being a muscular dystrophy carrier also comes with it a cardiovascular vulnerability in of itself. Now, if you combine both a chronic stress like caregiving with an already vulnerable system due to genetics, what are the outcomes of that? And not only for cardiovascular health are we really interested in better understanding this, but also even for emotional well-being and cognitive health. And so that is one of the next big questions that we are hoping to answer with the carrier trial. Next, please. So in summary, I think the bigger take-home points that I would like for you all to take away from this today is that, we want to, again, acknowledge the fact that caregiving takes a large physical and emotional toll. And this is no doubt also true of, individuals who are caring with Duchenne and Becker. It's hard to continue to caregive and do that role, which also comes with it, a lot of, meaning making and joy. It's hard to do that role and experiencing really high levels of anxiety and emotional distress. So it's really important that we find a way to also provide support for caregivers, in particular, obviously, within the context of this discussion, the mothers. And whether this is different types of interventions that are going to be more family focused, or if it's just changing modalities, we need to find a way in order to make sure that these issues are addressed for our caregivers. And secondly, the psychosocial implications of being a muscular dystrophy carrier really do require further study. And I'm excited, that we've got this opportunity, thanks to PPMD, in order to look at this question as part of the carrier trial. But it's really going to just be the start, I think, of a lot more questions to come about that genetic interplay with psychosocial well-being. Next, please. So thank you so much for your time, and I look forward to the panel discussion. Thank you.
Thank you, Dr. Jackson. As we discussed in our resiliency panel, that emotional health topic is something that can often be overlooked and is really important to be addressing. So now we are going to go to our full panel. Again, if you have any questions, please put them in the comment box below. Unfortunately, Dr. Flanigan did have to drop off this panel discussion, but I'm going to hand it over to Pat Furlong.
Great. Thank you, Eric. I so appreciate that. And thank you for the great discussion. It's really, the carrier status is, and being a carrier of Duchenne muscular dystrophy is really another diagnosis that women take on, right? And it's really hard to listen to, hard to think about, and what that means to you and what that does to you as a woman is really something we need to consider. So we have lots of questions that have come in. And here's a plug. PPMD has a Decode Duchenne, which offers free genetic testing for carriers for the U.S. and Europe. So if you are interested in having carrier studies, please contact Anne or Nikki at parentprojectmd.org, and they will certainly facilitate the testing with you. So a couple questions, lots of questions have come in, to be fair, and one of them, Stan, is when do you think carrier testing should be done? At what age? And what is this high CK level that what would you, in your view, would be a elevated CK?
Yeah, so by modern CK levels, an upper limit of normal would be around 200, 250. It changes over time, age, and also changes with exercise, other issues going on. So when we say elevated, it means that it's really at the upper end of that normal range and above. But many of the manifesting carriers who have some skeletal muscle issues often have CKs in the around 1,000 range, so kind of in a typical Becker range. And when a girl of any age has sufficiently highly elevated CK levels, I would do the genetic testing regardless of age. And part of the reason for that is you're testing for cause, you're not testing for the ultimate transmission later in life. I think you can make an argument, though, that many, with the data that Dr. Ma was showing, that the frequency with which women ultimately manifest during their lives of some type of disease means that the carrier state is, there's a substantial risk over one's lifetime. There's an active debate, and some geneticists, some genetics counselors won't do testing until after the age of 18. I personally think that's wrong. And there's clearly very strong evidence that a competent adolescent female can make independent decisions, and we ought to respect kids' autonomy. Kids are going to become adults, and we ought to respect their autonomy. So if capable of giving informed consent appropriately, regardless of any symptoms, I always favor testing. I think one of the things that we should be looking at is minimizing harm. And one of the things that we've done in genetics is sometimes created an overly paternalistic approach to it, that people can't make decisions until they're 18, which is demonstrably absurd. So to me, I approach it as, what is optimal for the family in terms of lessening overall anxiety, concern about this one issue. I tell everybody that every female should presume that they're a carrier until we prove they're not. Partly of that is that we don't want people to be presuming that they have no risks of muscle issues, or that this is not possibly a cause for high liver enzymes, and sets people down a different diagnostic path. So I would often test anybody manifesting. I would test it at any age that I observe the manifestations. I would certainly permit testing with reasonable consent and ability of the individual being tested at pretty much any age, and certainly by adolescence. I would not arbitrarily wait until 18.
Thank you. I totally agree with you. I think that adolescents should have their autonomy and should be considered ready for testing when they feel if the need is there. So, Mei-Ling, we have a question that's coming about tachycardia during pregnancies. So the question is, I've experienced tachycardia during both of my pregnancies. Has this been observed or reported, and could it be a sign of heart damage? And another just follow on was, I had VTAC VFib cardiac arrest 4 years ago at 43 during sleep. Doctors felt it was due to fibrosis due to being a DMD carrier. My previous echoes were normal, and I now have a defibrillator and have occasional bouts of VTAC, but no shocks have been needed. I've not had an MRI due to the device. Have you heard of this happening with fibrosis? And what should I do? How should I care for potential additional fibrosis? So that's a lot.
Thanks, Pat.
Yeah, I thought I'd wrap it up in one.
So I will say that we excluded all pregnant women from the study because you can't have an MRI you could, but we didn't have pregnant women have MRIs. I see a lot of pregnant women just outside of the muscular dystrophy patients, and tachycardia during pregnancy is quite normal. Your heart is supporting a fetus, and at about 14 weeks, that starts to really increase in terms of the amount of volume going through the heart. It peaks at about 30 weeks. I expect baseline heart rates to go from 60 to 80 at baseline. The lower rates are about 80 to support placental flow, 80 to 100. And then obviously, as you gain weight, movement increases that. And so baseline heart rates definitely go up in pregnancy. So tachycardia doesn't really bother me in pregnancy. That being said, in the context of being a carrier, I think there are other cardiomyopathy states that are certainly exacerbated by that same volume load that I was describing before. And so if you are a DMD carrier and you are pursuing pregnancy, I think it's not a bad idea to have an echo and to make sure that the heart function is normal. Chances are it will be, and someone can be reassuring in terms of your baseline heart rate. But knowing that you have a genetic mutation and knowing that you are at risk for cardiomyopathy, and then having the physiologic changes of pregnancy on top of that, I think deserves a thought. And so to me, I think getting evaluated and being looked at ideally pre-conception, and then at any juncture during pregnancy if symptoms arise is reasonable. In terms of the second question, that's a much harder question to answer. So I have been putting defibrillators in patients who have ejection fractions of less than 30 or 35 that I can't get higher than 30 and 35. The woman that I presented at the end does have a defibrillator that I had requested because it took me a long time to get her over 40 to 45. It took a while. And because I knew that she had had the MRI from decades before, that was lower. And because she did have also VT on a Holter, we elected to do the defibrillator as a primary prevention device. That's a long conversation to have. And I think each patient having a defibrillator is not nothing, both physically and emotionally. And so it's a long individual conversation. It hinges a lot on function. And so to have it in the absence of dysfunction is also a totally separate question. And I think has to be individually discussed. I don't think that I could say 100% it's necessary. If you had an event in your sleep, then it would not be considered primary prevention, it would be considered secondary prevention, and it doesn't surprise me at all you got a defibrillator. So that's a complex answer, and I would say requires individualized assessment.
Thank you. So the woman you presented, the 47-year-old, in addition to the defibrillator, can you tell us a little bit about the meds you put her on as well?
Sure. She was really on nothing when I met her. essentially on nothing. And we started with beta blocker because of that's what she'd been on for a short bit. I switched up her beta blocker because I chose one that was more arrhythmia acting, because I knew she had some of the arrhythmias as well. So we used metoprolol. We put her on an ACE inhibitor initially, and then converted to Entresto, which is a combination medication which has been demonstrated to be effective in heart failure patients if they have had a heart failure admission. That is a very difficult drug to get from an insurance standpoint. For her, it was justifiable because of her hospitalization. We also put her on spironolactone. We maximized the doses of all of those things, which is hard to do because of low blood pressure. But she was a trooper, and we pushed through and made some adjustments on things, but got her to maximal dosing on all meds within about 6 months. It took another 6 months, actually, for us to see a real change in her EF. So it was a good amount of time on therapies. I think the thing that we were so happy about when I saw her recently is that after she didn't recover, and knowing that she had had decades of having a low LVEF and fibrosis, I wasn't sure she would respond. And so even a little bit of her response was really positive for us. So
sounds like she's doing really well. So Jamie, in interviewing these carriers, I hear from, and I see on social media that carriers talking about the guilt, and Stan, you can comment here as well, please too. But because, while you carry this genetic mutation and you didn't do anything to do that, to have that happen, it still feels extremely hard to know that you're a carrier and your body is the creation, if you will, of this child, and giving him a disease that you didn't want to ever see happen. So are you seeing that as a theme through this? Does guilt play a part through the carriers considerably?
Yeah, thanks for that question, Pat. Definitely. And one of the things I didn't have the chance to talk about was the fact, as you were just mentioning, Pat, was that we had interviewed all of the women who had come through the carrier trial. And we're transcribing and coding that data. And that's yet another avenue that we want to look into, because I think you're absolutely right. The guilt that comes with it inevitably plays into their levels of emotional distress. And I will say, what was really interested in observationally in listening to the stories of these many women was that, they really varied as to kind of where they were in that progression of feeling guilty. And so for some women, when they were just finding out their carrier status, this was a really big hit for them. And it was hard to digest, and they were actually kind of in the process of digesting that with us in the interviews. Many women became really tearful. In addition to that, there were some women who knew they were carriers, and they've known that they were carriers for a while, and they would tell us, initially this was devastating. And over time, I have learned that this isn't my fault, and that, what has happened is it's given me some power to make decisions moving forward in my life that I didn't have that power before. And whether that's, making decisions about having additional children or how to go about doing that. And so, I think the take-home message for me was that, yes, while, this really did contribute to the emotional distress of a lot of women, understandably, there are also were women who represented the other side of that. And after they've learned this information and have also kind of come to terms with it and didn't carry that guilt any longer, even though that certainly was a significant part of their experience early on. And what I want to do with some of this information that we've learned from all these women is I think this can really guide us, even from a research perspective, moving forward to kind of better understand how that progression goes from initially getting a diagnosis of being a carrier and following that over time for some of these women, what kind of happens on the other side of that.
Thank you. Thank you, Jamie. Stan, I have one question for you as well. It's kind of it's two questions in one, so I'm going to say it all together. When you do genetic testing to know if the mother or aunts are carriers, in a case you think there is a de novo mutation, it will be negative, but both the mother and or the aunt have a probability of having a boy with Duchenne. So it's a little bit of a confusing question. If you see it, so I think what she's trying to get at is if you have a de novo, if you're a new carrier in your family and you're going to go back and test, what's the probability of the rest of them carrying that same de novo mutation? And then the other side of this I'd like you to comment on is many of the carriers that I know have talked about having miscarriages before or after every in succession, and some of them have talked about having children, a baby with Down syndrome, or a number of miscarriages. And so, can you comment on all that very, very quickly for us? That's a lot, I know.
Sure, I'll try to do that as quickly as I can. For the miscarriage issue, we don't see an association with DMD mutations. I think miscarriages are unfortunately a common phenomenon for all women and all pregnancies, and we don't understand their root causes most of the time. That's just fundamentally part of being human, unfortunately. And for other sort of mutations like Down syndrome, we don't see necessarily a strong correlation, but they're like everything. Down syndrome is reasonably common. Duchenne is reasonably common. Should we expect to see those two things existing in the same family at some rate? We should, just because there's a fairly large number of Duchenne and others. So we don't see those as clear associations. There are some instances of like X chromosome abnormalities, which would be highly enriching for a female manifesting who has XO, for instance, with Turner syndrome. So there are some exceptions to that. For the other, if a mom does not have the mutation and she has a son who has the mutation, no other females in her family before her, no sisters, no moms, need any genetic testing. They're back to population risk. Her daughters have a risk of inheriting a de novo mutation. And we would typically put that in the range of, sort of 1 to up to 50%, because we don't necessarily get to look at her ovaries. But on average, it's a few percent risk. So all daughters of her, even though she doesn't carry a mutation in her blood, should be tested. If mom has the mutation and her mother, grandma, doesn't, then sisters should all be tested, because they could also have had inherited the de novo mutation and not know it, and they're at risk. And again, each sister would be at a few percent risk. The testing that we can now get through PPMD is actually critically important for kind of going up that stepping stone. Many insurances don't cover things like carrier testing, which is critically important, or we have such a fractured health insurance system that moms, particularly on the poor end of the spectrum, cannot get testing, which is just shameful. And thank you guys for filling that gap. It's been amazing.
Thank you, Stan. No, I think it's critically important, and we can't discuss the healthcare in this country, or we'll be on for the next several days. But it is a right for all of us to have good healthcare, and maybe someday we'll have that. So, in fact, thank you so much. We're so pleased with this. One of the questions came in is where to get care. We have 29 certified centers in this country. All of them have these quality of individuals that are amazing and empathetic and smart, and they can really help us take good care of ourselves and our sons as well. So with that, I'm going to turn this back to Eric and Ryan.